they really start to drop that in their mid 30s, which is really kind of crazy. And that's the other reason that women, as you get older, your later 30s, your early 40s, have such a hard time getting pregnant because your progesterone levels just naturally decline at that time. And then your estrogen throughout your 40s kind of gets a little haywire. So before you're reaching menopause, you're suffering from symptoms and things that are going on inside your body for years before you actually stop having periods.
Hello, everyone, and welcome to Finding Your Wellness, a podcast sponsored by the Columbia Association. I'm Dr. Harry Oken, a community physician for over 37 years and the medical director for the Columbia Association. I'm proud to be working with CA for over a decade to help assist in their mission to improve the health and wellness of our community. I'm happy to introduce two guests today, Darin Zimmerman, who's a physician, and his wife, Laura, who is a registered nurse and nurse anesthetist. She's been a nurse since 2010 and a CRNA or nurse anesthetist since 2014. Both of them are passionate about preventative medicine and functional health, and they both have excellent training, and they're well trained in bioidentical hormone replacement as well as integrative health coaching. So today, we're going to talk a little bit about these areas, both andropause for men and hormone replacement for women. These conditions can be overcoming to people. They can cause exhaustion and brain fog and night sweats, and balanced hormones have a significant impact on the rest of the body, so they must be balanced. We're going to learn a little bit about bioidentical hormones, and then we're going to talk about andropause. Andropause is, for men, the male climacteric. Unlike the more dramatic sometimes phenomena that happen with women when their hormones decline, men, it's sometimes more subtle and gradual. And the term male menopause has been used to describe the decreasing testosterone levels that we begin to experience around 35 or 40. In fact, testosterone levels begin to decline on the average about 1% a year after the age of 40. And a low testosterone level can have many effects on men, just like when women go through menopause, it can have significant effects and sometimes unrecognized for a while. So we'll be talking about all of this. Let's start first with Laura and bioidentical hormone replacement. First, if you wouldn't mind, talk about the symptoms of early menopause and what most women experience.
Oh my gosh, there's so many things that can be attributed to either perimenopause, which is really like the time surrounding menopause, and that can be up to 10 years before a woman actually reaches menopause. And then with menopause itself, the average age of menopause in our country is 51, 52 years old. So really this starts impacting people in their mid 30s. And then for the rest of their lives, especially since our lifespan has really increased, the amount of time that a woman is going to be experiencing these things has just gotten longer and longer. And so there are probably hundreds of different symptoms that people talk about. Some of them are more common than others. So the things that my patients tell me that they're experiencing would be things like, I'm doing all the right things, but I have this abdominal weight gain that I just cannot get rid of this belly fat. I'm having horrible brain fog. I literally walked into this room and I can't remember why I'm there. Things like having trouble sleeping or new onset anxiety that wasn't really provoked by anything situationally. Heart palpitations can be a big one that we see. Irritability, just being extremely short with your loved ones or your kids or your husband, especially surrounding your menstruation. Different things like, I'm doing all the right things, but I just don't feel like myself. And I get that one a lot. Like they just say, I feel like a shell of myself. I'm just not who I used to be. A decrease in energy levels, significant fatigue. Those would be some of the biggest ones that just jump into my mind. And then there's also some that, like you can have weird tastes or sensations in your mouth. I mean, there's just ringing in your ears. There's really just all sorts of things that people can experience.
Diagnostically, this would correlate oftentimes with an elevated hormone level like the FSH or LH and a reduction in estradiol levels.
Correct. So if you are a woman that is actually in menopause, you're not having periods anymore. And so these labs you can draw anytime. And yes, exactly. The stimulating hormones that come from your brains will be elevated. And then the absolute levels of progesterone and estradiol will be low. And typically what happens is once you start having your period, you are not relying on your ovaries anymore to make the hormones, and you're relying on your adrenal glands. And so that's why cortisol comes into play a lot of times in these women as well, because the tiny amount of hormone that their body is making at this time, stress can impact that so significantly just based on their adrenal response.
So their adrenal response is blunted?
If they are having significant stress, then their adrenal glands aren't going to produce the small amount of hormone that is kind of like diddly squat compared to what your ovaries were making, but you can still have significant symptoms related to that as well. So really, like, we think that replacing the hormones not only gets rid of things like vasomotor symptoms, but there has been some data that it prevents a lot of long-term complications as well. When you're talking about cardiovascular health, I mean, estrogen is one of the hormones that helps keep your vessels pliable, keeps them flexible. So if you can start bioidentical hormone replacement therapy early on, and typically this is maintained for an extended period of time, then you can really reduce cardiovascular disease, cognitive decline. There's just a ton of stuff here. Bone density. Yeah.
So for our listeners, typically, classically, we would define menopause as the absence of period, menses, for 1 year.
Correct.
The message I think you're sending is, okay, that's true, but these symptoms of early menopause or premenopause can happen up to 10 years before that.
Yeah. So what happens, and I was just reading the statistic the other day, between the age of 30 and 40, your progesterone levels can drop up to 80%. And progesterone is really significant. We think of estrogen a lot of times in the female hormonal pathway, but progesterone is significant. There's receptors all over your body. So when you think of this new onset anxiety or trouble sleeping, it's really GABAergic. And so it's kind of like nature's Valium, or, some people might think of like drinking a glass of red wine, it calms them down. And so they really start to drop that in their mid 30s, which is really kind of crazy. And that's the other reason that women, as you get older, your later 30s, your early 40s, have such a hard time getting pregnant, because your progesterone levels just naturally decline at that time. And then your estrogen throughout your 40s kind of gets a little haywire. So before you're reaching menopause, you're suffering from symptoms and things that are going on inside your body for years before you actually stop having periods.
And of course, you're having all the phenomena that relate to that, changes at a very cellular level that are going on that you may or may not be aware of clinically. As you mentioned, Darin, bone density changes and receptor changes in certain areas of the body. One of the things I didn't hear you mention, was changes in libido as well as dryness.
So we think about the drop in estrogen that causes, people complain about vaginal dryness all the time. You're right. Or dry everything, dry skin, I'm itchy, dry hair, dry eyes. Yeah. Everything just kind of dries up. Absolutely. To your point.
And so the fix is, after you are reasonably certain that menopause or premenopause is responsible for these symptoms, is how you prescribe replacement.
Correct.
So how do you make that decision, and what's the general path? They've already had labs which confirm it. The history confirms it. Maybe the physical exam confirms it. Now you're going to go into the process of, okay, here's how we're going to fix you. And how do you do that?
So everything we do is really patient specific. So we take into account both diagnostics as well as the patient symptoms. And what we do is we come up with a plan with the patient. We educate them, which I think is super important to know what's going on with your body. And so oftentimes, menopause specifically, you're going to make zero hormones.
You're zero estrogen.
Exactly. You're essentially making none. It'll, like, on the labs, it'll say less than 5, like less than 0.1 for progesterone. So you really have no hormone.
Right.
And so what we do is we try and give bioidentical versions in the least or the most physiologic dose, which We start on the lower end and work our way up. So bioidentical hormone replacement therapy also takes some tweaking. So it's not like one dose is right for everyone. We start on the lower end. It often takes 2 or 3 dose adjustments to get it right for the patients, make sure that it's taking care of symptoms. And then we do track labs and diagnostics as well. However, sometimes it's hard to capture depending on the type of hormone replacement modality that we use. So there's so many different options. There's for estradiol, we do creams and patches. We, in our practice, really don't recommend the oral estradiol just because of the pathway it goes through your hepatic system. It conjugates into estrone. And so we really want to keep it in the estradiol pathway. So we use creams, patches for that. Progesterone, we can give orally, we can give in creams. And then also with estrogen and testosterone, we can use pellets. So we do pellet therapy in our practice as well.
I'm glad you mentioned the testosterone because women do need a little testosterone.
Yes.
It usually help with libido. And that's something that you probably deal with. One other piece to this, and that is what's happening in the pituitary gland. For our listeners, when your estrogen is low, the pituitary senses it, and the pituitary sends out increased amounts of luteinizing hormone and follicle stimulating hormone, and sometimes in a pulsatile fashion, right? It senses it, there's a big pulse, and then women actually have a reaction to that, right? They get vasomotor symptoms, they can't sleep, they sweat, etc. And this is like somebody clanging a hammer against the wall 20 times a day for some people, right?
Exactly. I mean, it's significant. People talk about decrease in productivity, inability to work. I mean, I see people at my job, oftentimes they're fanning themselves. I mean, you're uncomfortable. It impacts them on a daily basis. So yes.
Some women will go through menopause without even a burp, right?
Sure.
And other women are just absolutely a mess. And what I always say when it comes to me as a general internist, when sleep is disrupted, it so affects their immune system that the benefit of taking hormone replacement really outweighs not doing anything. And sometimes that's a tough sell for some women, by the way.
1,000,000%. And, there is a lot of safety data on the bioidentical versions of hormones and then different modalities. So, for example, oral estradiol in the literature has shown an increased risk for blood clots, even though it's bioidentical. But if you use the transdermal creams or the patches, there really hasn't been an increase in blood clots in those modalities. And so I think having conversations with patients about risk benefit and then choosing modalities that make sense for them. But really with bioidentical hormone replacement therapy, you can mitigate a lot of the risk that people are concerned about.
Big risk, of course, in this arena is breast cancer.
Sure.
I often say, if you look at the big breast cancer trials, the risk is there, it's statistically significant, but it's not what you think.
It's extremely low. And the other data, which is surprising and that we tell our patients too, is that the hormone replacement therapy does not cause breast cancer. There are people that are predisposed to the cancers, right, with genetics and toxins and all the other things. And actually, if you're on bioidentical hormone replacement therapy, the mortality, so you die less often if you get the breast cancer and you have the hormone replacement therapy versus patients that were not on hormone replacement therapy and got breast cancer. So, I mean, that's also an astounding talking point to talk about. So if you get breast cancer, you might not die if you're on hormones.
Yeah, I think we're going full circle now with our understanding of bioidentical hormones, and particularly as it relates to longevity.
Yes.
There is reasonable data that keeping balanced improves your health, improves your longevity, improves your likelihood of living longer, and probably with less cognitive decline. I think we're moving in that direction. And I think it's great that we have this tool to offer women who are very afflicted really by, perimenopausal or menopausal symptoms. So once you have somebody who you feel is balanced, how do you monitor them?
So we monitor them both with how patients feel. So we have different questionnaires that are subjective for patients to make sure that their symptoms are kind of staying at bay. And then we do monitor lab values, but also knowing that, again, they're not necessarily going to be the most useful tools depending on the modality of bioidentical hormones that they're taking. Because oftentimes, like for example, if you're taking a cream or a patch, the estradiol levels, even though they're having supreme symptom management, don't always show up in serum levels. So a lot of times we're really going off of how patients are feeling versus complete lab data, if that makes sense.
I mean, I think it always comes down to how you're feeling. And sometimes proving it, or confirming it with, diagnostic studies. Well,
Yes.
This is a great discussion. And I think it's going to be very helpful to our listeners. So let's go to the male side now and talk to Darin about andropause. And, as I said earlier, men with andropause oftentimes don't know they have it. They're looking for, why do I feel so bad? Or why am I sitting on the sofa so long and I'm not interested? And they're not interested in a whole variety of things. Decreased energy, no motivation, can't concentrate. I personally can usually tell when I meet someone, when I shake their hand, oftentimes, what's their testosterone. And then when I fully examine them, I can usually tell, not always. So it is part of an annual phenomena that I'm assessing whether or not to check testosterone levels on men.
Yeah.
So first, let's talk about how you feel, in addition to the physical examination and the history, how you approach this diagnostically with laboratory studies.
Yeah, I mean, I think that's a really interesting question because historically we look at a testosterone level, but it's also really important to check levels of things like estradiol and luteinizing hormone. As you talk about, that's going to be what sends the message from the brain to the testicles to make testosterone. And so
how about FSH as well, or mainly you like to focus on LH?
Mostly LH. I haven't found FSH to be as beneficial at making the decision of like, is this primary or secondary hypogonadism? Although I will say if the LH is significantly off, then we probably would also obtain an FSH and a prolactin level just to make sure we're not missing something else.
So the first screen you're going to do is FSH, estradiol, testosterone. How about free testosterone?
Yes, and free. So I was going to say total and free.
How about sex-binding hormone?
We send that. Yes, we do. We end up sending a battery of labs that most people won't have been as familiar with in terms of patients. They may not have heard of, a DHEA level or a dihydrotestosterone level or a sex hormone binding globule level. And when we think about male hormones, it really is more than just testosterone. So we touched on LH, but when we talk about SHBG, the sex hormone binding globule, this is what actually carries testosterone throughout the body. The problem is when the testosterone is attached to it, it's inactive. That gets to your point about also measuring free testosterone. So testosterone that's not bound to sex hormone binding globule. As men age, the SHBG goes up, which means that more of the testosterone is bound and less available to do its job at the cellular level. Dihydrotestosterone is another one where it is a metabolite of testosterone, and it's about 3 times as potent for those receptors. And it does some very beneficial things. It helps with libido and, secondary sexual characteristics. But one of the other things that it does is it contributes to like prostate hypertrophy. So you may tend to see people in a more proliferative, meaning the tissues are growing more if they have too much of this DHT circulating. So, and then DHEA is another sex hormone. It's sort of the precursor to testosterone. It's made in the adrenal glands.
Estrogen too.
Exactly. And estrogen. Yeah. And so as we age, that tends to go down. If we're under significant stress, the adrenal glands and the stress response is designed to, they're designed to keep us alive, right? So if we are under stress, our body thinks fight or flight mode. So we're putting out our stress hormones, our cortisol. We're not producing as much of the sex hormones. So if your DHEA level is going down, then your testosterone level will be going down.
So now, one thing that I think, I don't know if you agree with or not, but when I'm investigating, I want to look at testosterone levels between 8 a.m. and 10 a.m.
We recommend morning testosterone as well, and that seems to be the most validated.
Right, and that's what the American Endocrinology Society suggests for starting testosterone replacement. I think they barely focus on total testosterone, but 2 levels less than 300. But
yeah, you won't be able to get it approved if you don't have it drawn in the AM,
right,
as well.
But 2 values, not just one.
Okay, correct.
300. But that's just a very small part of the story, right? You can have a normal testosterone, and yet your free testosterone may be off, or your sex binding hormone may be high, right? And you may be missing it. So I think it's the picture's not quite that clear for a lot of.
And let's take us another step backward from that, or another step back, not backward. Like zoom out a little bit. If your testosterone level is 400 and you feel like garbage, if you're just unmotivated, depressed, anxious, cholesterol levels been going up and you don't really know why, you're not making the same gains at the gym and you don't really know why, it almost doesn't matter that the testosterone level is 400 because you're symptomatic. And so what Laura and I do in our practice is we very rarely go by normal lab value markers, because normal has shifted as the population has become less and less healthy or more and more abnormal. That range of normal values reflects a less healthy population. And so for us, we don't go by, 300 for me is way too low a level in almost anybody, in any male, to wait until we're going to initiate therapy.
Now, how about if they're 75? Is 300 still too low?
I think it depends on if they're symptomatic. That's what I mean by that is if somebody is coming in with classic symptoms and their level is 350, I'm not going to wait till we hit 295 to start therapy.
One other wrench to throw in, and that is 2 out of 3 people in this country are obese or overweight. Sex binding hormone increases if you're obese, right? Yes. So for obese patients, you're probably not going to get an accurate reading of their testosterone.
That's true. The other thing about obesity is, you have your aromatase, which actually turns testosterone into estrogen, and that hangs out in the adipose tissue. Right. So the more obese somebody is, the more likely they are to convert their testosterone to estrogen. One of the reasons that's so important is that our brain senses estrogen levels. And when the estrogen levels are high, we turn off our LH. We say we have enough sex hormones circulating clearly because you've metabolized to estrogen. And so then you're right, we tend to kind of go down this negative feedback loop.
Okay, well, after you've made the diagnosis of testosterone deficiency, then you have medications that you prescribe. Talk about them.
I will. I also do think it's really important. I think a lot of things start with lifestyle modification.
Good point. I like that.
So one of the things that we do differently than what has been our experience with the providers we've gone to see in the past, we are not as quick to pick up the prescription pad. We look at modifiable factors that could be lowering testosterone or raising sex hormone binding globule, right? So as you say, if somebody is significantly obese or maybe not even obese, just very low muscle volume in their body. We will typically start with lifestyle interventions like diet, come up with an attainable exercise plan, because sometimes most people need to ramp themselves up. You can't just expect to overnight start on an aggressive exercise regimen. So we'll look at those types of things. Where can we modify stressors, right? Because that's also a huge one. And then if we are going to start with testosterone, we have a number of tools at our disposal. Like I said earlier, we offer pellet therapy for people who maybe aren't going to remember to take a medication, or like in the form of a cream every day, or aren't going to want to inject themselves or come and get injections once or twice a week. But we have a lot of different things we can work with. Sometimes, honestly, it's as simple as giving somebody DHEA and allowing them to kind of bring up their levels that way. We have folks whose primary issue is a luteinizing hormone issue. And so we use a medication. Typically, you may have heard of the medication clomiphene or Clomid. We use a different isomer of that called N-clomiphene, which essentially doesn't have any of the estrogenic side effects.
That promotes the Leydig cells in the testicles to produce more testosterone.
Yes, by stimulating the growth luteinizing hormone. And typically we can actually see an increase of 150 to 200 points in testosterone value just from that, without ever having to go through the pathway of giving somebody testosterone, because it's an important decision and it depends on where people are in their life. Some people, fertility is very important to them, and testosterone may affect that significantly. Additionally, when you start giving somebody
with testosterone, you're going to actually decrease LH. Right?
Correct. When you give somebody testosterone, the body doesn't want to make anymore. So you shut down your body's function for itself, and you become very reliant on this external source. And even if you stop it, even after 6 months, you still may not get back to the level you were prior to starting it. So starting on testosterone therapy is not something we take lightly.
That's great information. A couple other things along those lines. You talked about DHEA, dihydroepiandrosterone.
Yes.
A really important pathway where estrogen comes off of that and testosterone comes off of that. And so in patients that you measure DHEA in and they're low, that might be a really kind of very benign way of getting some ideas, right? And that's, of course, available without a prescription, but you have to get a good preparation because you never know where you get it from. What do you prefer for DHEA?
We like Designs for Health. Yeah, that's a very good supplement company that we use.
Reputable, they assay it, you know what you're getting. That's very important.
One of the things, just to touch on, though, it's also really important to continue to look at estradiol levels in men, because you can give them DHEA and they might convert it all to estrogen and end up feeling worse. And we actually have seen unfortunately, a number of our patients have come to us after being started on testosterone therapy elsewhere because they feel terrible. And when we look at their labs, they essentially have
more estrogen than
double the estrogen that you would want to see in, a young woman. And so
a great point, and I think that's not well known. And I would bet that the people who do poorly on DHEA and get more estrogen are probably obese.
Yeah, it's definitely, I haven't, sat down and looked at that specifically, but it makes a lot of sense. And in thinking through our practice, that does seem.
And, one of the interesting things that I see in my practice is, although, it's recommended to do bone density scanning on people who don't have risks at age 65, it's rare to find a woman whose BMI is elevated that has significant osteoporosis because their fat cells make a lot of estrogen.
Right.
The fat cells make estrogen.
Yes.
Well, great. Now, a couple other things about estrogen, testosterone replacement. So you mentioned that certain types of testosterone promote prostate enlargement. And
Correct.
one of the concerns, and it's still a warning on the FDA insert about prostate cancer. My experience has been, even in patients who've had prostate cancer and treated, I've never seen a recurrence related to testosterone replacement, because many of these people do need testosterone replacement.
That's accurate.
What's your experience with that? PSA screening, et cetera?
That's so we will check PSA on our patients prior to initiation, and certainly as they're undergoing therapy. And, we've had patients who either have prostate cancer, have had prostate cancer, or just have significant BPH or elevated PSA. And we do consult with urologists to help with some of the decision making, because what we don't want to do also is we definitely don't want to overlook something that could be potentially problematic. As far as the prostate cancer risk, I do think you're right. It's been shown that testosterone replacement does not lead to an increased risk of developing prostate cancer. You are also right, though, that there are warnings that it is an absolute contraindication if someone has active prostate cancer. And some of that is changing. Like, a lot of the urologists in their patients are prescribing testosterone therapy because the symptoms of androgen deprivation and things that have been a mainstay they're debilitating.
There's even data in people who are not doing well with metastatic cancer that get a benefit from testosterone administration. This is sort of new information that was actually published down at Duke. So there actually is a category of people with advanced prostate cancer to take testosterone replacement to turn off the prostate cancers. It's fascinating.
Yeah. I think that some of it, one of the things to be mindful of, and I think a lot of urologists will have already started some of these medications, like things like finasteride, which kind of preferentially shut off that dihydrotestosterone pathway. That can be a very powerful thing, if nothing else, to slow the growth.
Next black box warning is, of course, heart disease. Tell me your view on that.
I think that testosterone, again, I think sometimes these black box warnings are a little bit slower to get taken off than they are to get put on. But I think that testosterone replacement has also been linked to a decreased risk of things like acute coronary syndromes and stroke in certain patients. Now, for us, another thing that we tend to do is not look at lipid profiles in the custom, just HDL, LDL. We tend to look at apolipoproteins A and B and try to see density of these lipoproteins and whether or not our patients are predisposed to plaque formation. And if they are, depending on their lifestyle and risk factors, we may send them for a coronary calcium score prior to starting on any hormonal replacement.
Certainly something to put out there and be aware of, not necessarily a contraindication. Yeah.
Yeah. And I think, listen, if you can get somebody off of that sort of unmotivated, somewhat depressed, doesn't want to engage in any of these productive things, if you can get that person motivated, even just to exercise, you've already reduced their cardiac risk, I think, much more than you've increased it with testosterone. I think sometimes we prefer not to start with medications, but some people really need to feel better before they can engage in their health.
Yeah, I agree with you. I mean, somebody who is near sarcopenic, no muscle, can't do anything, you'll help them. Well, this has been a wonderful conversation about bioidentical hormones and for women, and andropause and testosterone replacement or other replacements to improve this. I've learned a lot from you. Thank you.
Thank you for having us.
Sure. What I learned is that, this is a real specialty area. You really need to know what you're doing. And could you tell our listeners how they get in touch with you if they want to pursue this a little bit more?
Yeah, our website is actually rebalancehw.com. And you can go on and we have, we call them discovery calls. So you can schedule on Calendly a free 15-minute call to learn about the practice to see if both the patient and we would think you would be a good fit for the practice. And then we're also on Instagram at rebalancehw and Facebook as well. And we're always available. You can email us. Our email's at the bottom of our website, but the way to get to both Darin and I is info@rebalancehw.com. We love educating and talking to people. And I think that it's a really important area that is completely underrepresented and underserved. And I did want to say like one other thing about risk and hormone replacement therapy in general is we're really aiming for those physiologic levels. So we aren't trying to shoot for levels that are super physiologic. Like we're trying to get to levels that your body has been accustomed to or would naturally support. And so I think that's important to remember as well. Just a little side note.
That's a great message. And it's not just about the medication, it's about lifestyle and good medical care to follow up that what you intend to create is in fact being created. Great message. Well, thanks for being our guest. It's been a terrific discussion. It's great to meet you both. And thank you to our audience for listening. And thank you to the Columbia Association for sponsoring Finding Your Wellness. You can listen to all of our podcasts from Finding Your Wellness by typing into your browser findingyourwellness.podbean.com. That's findingyourwellness.podbean.com. This is Dr. Harry Oken for Finding Your Wellness.